The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell with Leading Age Michigan, and we want to again welcome you to our September 11th Safe and Calm webinar. As we take a moment this morning in remembrance of September 11, 2001 and all that we had lost, we also want to remember those that we have lost to this COVID pandemic and all of the frontline workers and first responders who continue to serve those in need every day. Again, a lot has happened in the past week since last we met. Yesterday, we passed the 6-month mark since the governor issued her first emergency order. And we're still facing continued COVID caseload, although recent data, at least for a while, has been a bit encouraging. Today, we've made a few tweaks to our standard agenda. We will start, as usual, with our advocacy update presented by Dalton Hervel, our Director for Public Policy. And then we're going to follow with a very short situation update and move on to the CHART report, CHRT report, which was commissioned by the state to evaluate the regional hub program. And it's been partly issued. The full report is still out, and we'll take a few moments to review that. We will go through the recent updates and guidance as usual, including the new visitation guidelines. And we had planned to review the nursing home updated infection control survey tool and all the changes in it, but we had so much other material we will have to hold that for next week. So with that, we will turn the mic over to Dalton, who will present the advocacy update.
Good morning, everyone, and welcome to our Friday call. We have a couple of things to cover this morning. We'll be covering a lot of bills, but in generality, as a lot of these have just been introduced or have seen their first action in a while and are early on in the process. So we're not going to take a super deep dive into a lot of these, but we'll be covering the basics. So House Bill 5929 is the first thing we're going to cover today, and this is a bill that would allow for license reciprocity for those who have a healthcare license in Canada who would like to practice in the state. The bill specifically says that a person who has a healthcare license in Canada who meets the education requirements in Michigan would be eligible for licensure. Those requirements would meet the education requirements for Michigan. This was in place between 2006 and 2012 when in 2012 the bill sunset, and this bill is looking to make this a more permanent change. It's interesting to note that Canadian healthcare license workers would still need to apply to the state and still pass the appropriate exams for their license to be eligible for practice in Michigan. I titled this slide Blast from the Past because we're going to be talking about some things we've talked about on previous Safe and Calm calls here. A new version of the healthcare liability bill that we had talked about on previous calls that would exempt healthcare providers from civil liability for COVID damages has been introduced and is in committee. This is House Bill 6159. This is an exact duplicate of the bill that the governor vetoed just last month, and debate so far has been shaping up to be very similar to the last debate, with similar stakeholders falling on both sides of the bill. They're hoping that this time, by attaching this bill to a larger larger liability package that includes liabilities for schools, small businesses, and the government itself, maybe this will get through. We'll be able to get something done. Also, yesterday, another bill was introduced by Senator Lucido to not allow COVID positive residents to be in nursing homes. This bill is not as specific as the last one and also includes exceptions so that Michigan can still function as a regional hub model, or still function within the regional hub model, but nursing homes would have to demonstrate an ability to separate COVID positive individuals from non-positive individuals before they could take COVID positive residents. And those who have not demonstrated that to the department would no longer be allowed to accept COVID positive residents in their nursing home. A long awaited and this bill's been attempted many times, House Bill 4098, which was introduced early in the legislative process of last year, I think. The medication aid bill is still in the works and has actually been revived and is in House Health Policy right now. It got a substitute last week, or this week, excuse me, it's Friday. And this bill would allow for the use of medication aids and SNFs and would create a train-the-trainer model to train these aides. And this medication aids could administer regularly scheduled medications to residents who reside in SNFs. But the aides must be supervised by a professional nurse or a licensed practical nurse, and aides cannot administer injectables, controlled substances, or the initial dose of any medication. The next slide has the qualifications for what a person needs to have to become a medication aid. And they're fairly straightforward. I think the most complicated one here is that the nurse aide will have to be able to demonstrate to the department that they have completed at least 2,000 hours of direct care for a 2-year period immediately following the date of the application. And so you need a nurse aide who's had at least a fairly lengthy career and spent a lot of time doing direct care to become a medication aide. You can see the other qualifications here are things like submitting the application, paying the fee, completing the training program, and meeting the general requirements for licensure. Yesterday, the governor announced a Future for Frontliners program that can affect many people on staff in nursing homes. This program offers scholarships for community college and provides assistance or scholarships to help individuals graduate high school if they have not already obtained their GED in Michigan. The FAQ link is attached here that has all the information for the program, and the application link is there. Those who qualify are on the next slide, so we can run through that real quick. This is really designed to help those who have not already achieved some level of education, achieve some level of education. So here are the eligibility criteria for the community college pathway. The scholarships are to provide tuition-free or help provide tuition-free community college for those who have been frontliners. The requirements are being a Michigan resident, having a high school diploma, having worked in an essential industry at least part-time for 11 of the 13 weeks between April 1st and June 30th. I did check, and healthcare does count as an essential industry. And the person must have been required by their job to work outside of their home, and they have not yet earned an associate's or bachelor's degree, and must not be in default on a student loan, and must complete the scholarship application by midnight of December 31st of 2020. That is actually the application deadline. So if you do have anyone who's interested in this program, please make sure they do submit their scholarship application by December 31st. I had hoped to have a budget recommendation here. We are expecting that in the next couple of days. Yesterday at our Leadership Institute, we were excited to have the House Fiscal Agency Director, Marianne Cleary, join us. Sorry, just got a little bit of feedback there. We were excited to have her join us, and she actually had to leave our session early because they were holding some of these last-minute meetings that you typically see come up when they're getting close to a deal being done. And before getting started, she said we were only a couple days away. So expect a budget announcement within the next couple days. They do plan to be working over the weekend, so it is possible something will come out this weekend, but more than likely it'll be sometime next week.
All right. Thank you very much for all of that, Dalton. Before we get into any questions, each year Leading Age Michigan is thrilled to spotlight the new and innovative programs and services displayed by our business partners at our Solutions Expo during our annual conference. During this historic and challenging time, we would like to celebrate our business partners who have maintained their commitment to our members during our short delay. Please thank our business partners by supporting their programs when you are in need of their services. As of right now, it actually does not look like we have any questions. So if you have anything, you can go ahead and type that in, and we will probably go over it at the next break so we can keep moving.
Okay, thank you, Blake. So now we're going to move on to the situation update for this week. Earlier in the week, the governor issued some graphic reports of Michigan performance against other states, mostly the surrounding states to Michigan, but from this first slide, you can see that she threw Texas in there as well. So this is the number of daily cases per million over time using a 7-day rolling average. And you can see that although we peaked earlier than almost every other state, actually, we recovered quickly, and our current caseload per population is much better than other states. However, experts are saying it's still too high and obviously not at this point trending downward. This next slide was also part of the governor's presentation and includes the number of daily tests per million. And you can see that comparatively, we do a lot of testing, second only to Illinois, based on the states represented here. This is our standard 7-day rolling average of new cases for the past 60 days. We've had to alter our methodology a bit since the department no longer reports on Sundays, but these are still 7-day averages. Note that there's still some up and down in the caseload numbers, but overall actually seems rather stable, but definitely not going down. We are happy to report, however, that we had a decided increase in the number of deaths using, again, a 7-day rolling average in the past week or so. So hopefully that will continue. And so here is the Michigan Safe Start map as of yesterday. Our overall positivity rate is 3.4%. And the governor did really remark this week how well we are doing. But if that's the case, we're wondering why this map doesn't seem to be changing. It's been like this for a month with red high-risk areas over on the eastern side of the state. So we will now review the long-awaited visitation guidance issued just yesterday from Dr. Gordon at MDHHS. This emergency order applies to pretty much all senior residential settings, including independent living and unlicensed assisted living. So I have a lot on these slides. I'm not going to read them all, obviously, but I wanted to make sure that we captured them if you wanted to, all the issues, if you wanted to use it as a resource later. The order is designed to build on the June 30th order that allowed visitation for certain end-of-life or critical health situations and for ADL assistance when residents had been negatively impacted by the isolation. So those exceptions to the visitation restrictions still remain intact. Outdoor visitation is obviously preferred when possible for any of those visits, and this guidance is pretty much specific to outdoor visitation. So basically, the order allows outdoor visitation as long as there have not been any new COVID positive cases in residents or staff for the past 14 days, and there's no determination that the facility is unsafe for visitation based on local epidemiological conditions. And we're assuming that that means that the community has a high rate of transmission. That might be a case where the local health department might tell you that visitation, outdoor visitation may have to cease. So outdoor visitation can be conducted within the following rules: by appointment only. Facilities can set reasonable time limits on these visits. Visitor arrivals and departures must be logged, and all visitors must provide contact information and a test that they will notify the facility if they develop any signs or symptoms of COVID. Facilities must limit the number of visitors to a maximum of 2 at any time. Visitors must be willing to wear a face covering, adhere to the hand hygiene practices, or if they're not willing to do that, they can only visit remotely. Visitor entry must be limited to specific entrances. This is not really new. Where there is screening, and of course you must restrict anyone with symptoms, recent exposure, or who might be under observation for COVID in any way. Additional protocols. Facilities must make hand sanitizer, hand washing facilities accessible, and they must post information on proper hand washing. They must make staff available to assist with transition, and they keep calling this transition. I really think they mean transportation and setting up. I suppose that's transition, but to me that seemed like an odd word. They have to be available to assist with transition of residents. They have to monitor the visit, and they're also responsible to make sure that cleaning and disinfecting occurs after. And so all these visits have to be supervised. The facility has to educate the visitors on any additional PPE that might be required. I'm not sure I understand that that would happen very often, because if you require a whole lot of PPE, you're not going to have visitation if you've got cases in your facility. Ensure visitors follow social distancing, and that there is no physical contact with either residents or employees during the visit. You can limit the number of overall visitors in your facility at any given time based on spacing. If you can't maintain social distancing, then you've got too many visitors coming in and out of the area. Look at your infection control capacity and other factors to identify how many visitors you can have safely in your community. Staffing might be something you might want to look at as well. Advise against sharing food between visitors and residents. Facilities are required to communicate with residents and families to inform them of these updated visitation protocols. But of course, you must prohibit any visits to anyone who has symptoms, under isolation, or any kind of observation for illness. So some additional outdoor visitation rules. Of course, you must allow 6 feet between persons. They suggest that tables could be used to help with that, marking areas, 6 feet distances, and signage might assist with that as well. Outdoor areas must have shelter from the elements and the sun. An employee or volunteer trained in infection control measures must be close enough to observe and ensure compliance with all the rules. There is no specifics about the infection control measures that you might have to train to. In other words, there's no training program that seems to be required here. We suggest that maybe you look at developing a protocol using the basic hand washing, hand hygiene, social distancing, standard precautions, universal source control, and of course having them understand all of the rules to visiting. But you do have to monitor these visits on an ongoing basis. Well, in the last part of this seemed a little confusing to us. Medical service providers, if we're reading this correctly, and this is a challenge, but medical service providers are not subject to the visitation restrictions in Executive Order 174, but they have additional requirements as well. Services must be provided out of doors if possible, or in well-ventilated areas. So persons like therapists, speech therapists, occupational, physical therapists, etc. Other essential workers can provide services, preferably out of doors. But if indoors, you should be in a well-ventilated area and restrict these providers' movement in the building. And of course, they're subject to the same PPE and testing requirements as other staff. For non-medical service providers, the same thing kind of holds. They are not subject to the visitation restrictions in 174. And they can be admitted to the campus when there is an actual or potential negative impact. So they use an example of hairstylists here. So I'm not sure about the actual potential negative impact related to that, but they use an example of hairstylists. And again, the preference is that they serve out of doors, but they can be indoors in a well-ventilated area. Services that are non-essential, non-medical, can only be provided to persons who are negative at the time in terms of COVID, or they are past any infectious period. And of course, these persons are also subject to the testing requirements if they're coming into your building on a routine basis. So we're going to take a pause here and take questions. I would assume there probably are going to be some.
Yes, there are.
We do know this is a brand new guidance.
All right, so we have questions rolling in, so I will just pull those up and start getting right to those.
Okay.
All right, why do they have entry criteria when the visits are outdoors?
Well, I think that you have to screen. You have to figure out how to screen these persons regardless of whether they're visiting indoors or outdoors. So if they, I guess it's possible that you could have an internal courtyard that if you had a very close, dedicated, perhaps place of entrance near, I wouldn't let them go through the entire facility, but it's possible that they could enter one door. I don't know for sure what the scenario was that was in the state's mind when they said that. But I think that the point is that you still have to regulate the traffic and the pathways, and you also have to screen and make sure that they meet all the requirements and do the attestation and give you their contact information. So I do understand that there's a conflict in that idea, but I think that basically the idea is that you should have a very, very structured process that allows entry in one place.
Okay. Does that mean 2 visitors total per visitation time slot, or 2 visitors per resident if there is adequate room to provide multiple visitation locations that can be supervised?
Right. It's 2 persons per resident. 2 visitors per resident, allowable maximum at any given time. And the how many visitors you can allow on your campus has to do with your capacity. And I would think that that'd be staffing capacity, space capacity, and whether or not you can provide enough areas out of doors where you can provide shelter. So you need to identify what your maximum visitor capacity is at any time, and that's different from the 2 visitor per resident rule that's also listed in the guidance.
Okay. What happens come winter?
That is a very good question. I wondered that as well. The timing of this to me feels a little late. I don't know. I'm assuming that on a good day, if it's warm, not too cold, you could still have persons out there, but I think snow, ice, inclement weather, of course, is going to preclude this kind of visitation. We don't know how long it will be until indoor visitation is opened up, but at this point, this is all the state is allowing.
All right. Is there any indication that concurrent visitations must each have their own staff volunteer supervisor, or can one supervisor monitor several concurrent visits?
That isn't clear in the guidance. It's rather silent on that issue. My take on this would be that as long as you have someone supervising actively in full view of a visit experience, that would be adequate. So I would think that you could have more than one visit being monitored by one person if that works out logistically.
Sorry, I have to keep scrolling up to the top here. While this may be obvious, can we assume tours of independent living can begin?
No, I don't think you can. I went through the guidance with that in mind and did not see a mechanism to allow external people into your facility who are considered non-essential or who are not a medical provider, which they did open that up. So I don't really think, our read is that it's rather silent on this, but there's nothing in here that allows that. And the visitation executive order 174 precludes it, and that is still in place.
Okay. I'm assuming the therapists are those who may be externally coming in and not those who work for you. Those who are our staff, they can do therapy in the resident room, correct?
Yes, to my understanding, I believe that those are considered essential employees. However, I think that there's been some, I don't know if it's conflicting guidance, but lack of clear guidance about therapy and how it can be provided during the pandemic. But I would assume that those are essential employees and that and those are essential services over time. You certainly wouldn't want to stop PTOT and speech during the pandemic for people who need it. So my assumption is that those are for contract employees that are external to your facility, yes.
Okay. These rules are confusing, especially when the visits are outdoors. Some of these rules sound like indoor visits, which I didn't think we should be doing.
Yes, you're correct. I found this guidance hard to read, and we haven't even had it 24 hours to digest it all. It did seem to me that there was some discussion about indoor visits, but those are only for the medical providers who are external to your facility and or some non-medical service providers. And those are only if an outdoor visit doesn't work. So other than that, indoor visitation in our read of this is still prohibited.
All right. I thought the hairdresser needed to be tested if they were in the building more than 8 hours per week, see 3B.
It does say, and the 8-hour rule, which I wasn't very clear about before. My understanding is that if a single person, one single person who doesn't change week to week, a single hairdresser comes in or some other service provider comes in weekly, contractors who come in weekly, they have to be tested. Yes, they have to be tested every week along with your staff as long as you are in an area that requires weekly testing. And even twice weekly if indeed you're in a high-risk area.
Okay. Does this mean telehealth is no longer required?
No, I think that there's still a huge focus on using telehealth whenever it's feasible and workable. I wouldn't say it's no longer required, I think that it is preferred if it meets the needs of the resident and limits the number of people moving in and out of your facility.
Okay. Order says outdoors or in a well-ventilated area. Sounds like this is being interpreted as outside only. I think we already.
No, I think that part of the dilemma is that very small closed areas are places where it's more likely to spread the infection. But, you know, PTOT and speech out of doors doesn't make sense either all the time. And I think that especially with winter coming on, these people are allowed in your building, but you need to have an open area. So you need to look at your service area for these services and make a determination whether or not you have enough ventilation there. I think that that's what they're saying. But that is the only exception to the internal or in-facility visits. But I don't believe that it says that outdoor only. I believe that I would not want a hairdresser doing hair care outside. I don't know how that'd be possible or easy.
Okay. If we have a secured area with a direct entrance, must they be screened outside before entering the building? We're concerned about temps being accurate with weather getting colder and people being outside.
I don't know. I think that a lot of that's going to depend on how you're structured. If you have a way to perhaps let people get to the front or a foyer or something, that might work out. But in reality, I think that for most facilities, you would be screening out of doors. I think it depends on your structure, and we'd have to look at it. You have to have policies and procedures that align with what the needs are. I think the best thing is to avoid having people come in your facility if you can, but how they enter whatever area they would be to be screened in, that is, there needs to be a clear pathway. You don't want people wandering all around the building. So you have to decide pathways, you have to decide how to get them screened. I don't know the accuracy of thermometers indoors or outdoors. I suppose it depends on the weather, but if the weather is inclement, you're not going to want, not going to have outdoor visitation anyway. So I don't know how big of a deal that would be. I'd have to think about, I think you should think about the structures and how you're planning to arrange these outdoor visitation areas.
All right. The emotional well-being of the residents have been impacted by not getting their hair done. Does 3B then allow for hairdressers to be allowed into facilities if the protocols are followed?
Yes, I would assume that. Make sure though that you have a good space for hair care. Some of the beauty shops are very small and very close, and I think that you would have to be careful there with ventilation. But as long as you have a good and open space, yes, that's the way I would read the guidance.
All right. With a staff person watching at all times, how does this not conflict with privacy rights?
Well, first of all, I think that some privacy rights are have to be more flexible during a pandemic. That's the first thing. But also, it doesn't mean that you have to be within 6 feet, just 6 feet outside of the visitation. You can be further away from that. So I think that there are still privacy options. You would have to make sure that you set up your areas so that whoever is supervising isn't really part of the visit, and that they can see what is happening, making sure that the rules are being followed, and yet not intrude.
Okay. Can you please repeat what you said about indoor visits for family? It should be in a designated area.
Generally, I think indoor visits for family, using the exceptions that are written in the June 30th Robert Gordon guidance. My understanding is that they can be in a unit if that's a private unit, or there can be a designated area for them, depending on what the needs are and your structure. They do need to be very careful about where they are allowed to be in the building. In other words, they shouldn't be wandering all over the building. They should have a direct pathway that's clear to them about where they can be and where they can go. Social distancing, and of course, cleaning and disinfecting any kind of visitation area in the building is required after. But I don't believe that they are confined to a vacant room. I believe that they can happen in the resident unit if that is a private room.
Are SNFs able to have hairdressers in facilities now as long as they are screened?
Well, the actual guidance says that the person getting these services has to be impacted by the lack of services. So I think that's rather vague, really, and I think that it wouldn't take much for some persons to be impacted negatively by not getting their hair done. But that is the basis for the service use. Any kind of non-medical service use in the facility is supposed to be based on the resident need and their negative impact by not having it. Having said that, you can allow them in your facility if it's a well-ventilated area, and the service is obviously really needed by the resident. And of course, they have to be tested on a weekly basis, just like anyone else, the hairstylist.
All right. So can we have podiatry in the building and eye care and dentist, excuse me?
Yes, I would say that you can, remembering that if they're in the building, they have to be in a well-ventilated and not a close, tight area. And again, they're subject to testing and PPE as well.
Okay. Can therapists come into facilities and hold group therapy sessions?
I would think so. You would just have to apply all of the social distancing requirements, hand hygiene, masks, etc., as you would any other kind of service or care that you're providing. But I don't see anything in the guidance that would preclude that.
Okay. If a visitor visits more than 8 hours per week, will they be required to be tested?
There is no requirement that visitors be tested, although the CDC recommends that you might consider it if there is a person who is visiting frequently and you're in an area of high transmission. So I think that that's a facility decision or a health department decision. You might confer with the health department if they think that's necessary, but right now there is no requirement for it.
Does 3E in the order allow for indoor visits for family and friends?
No, not outside the exceptions that are in the June 30th order. I don't remember what 3E is actually off the top of my head because I don't have it in front of me. But I didn't see anything there that just allows indoor family and friend visits. Outside of the exception rules for end-of-life care, critical changes, and ADL assistance for those who are failing because of the isolation.
Has anything been said regarding opening group dining?
No, group dining, as far as we can see, is still closed.
So hairdressers can provide services outdoors, but would require some kind of medical prescription stating actual potential negative impact to a resident for indoor services, correct?
That's a little unclear. We do know that pretty much you have to have documentation based on the Executive Order 174 in order for family and friends to come in and visit for those accepted situations. So I would probably assume that you should document in some way. I don't know that you need an order. I think that you just need to document that. Well, I guess you do need a clinical statement based on the executive order, so it might not be bad, but I wouldn't have called it an order. You need some documentation that the person's failing because of the lack of service or isolation in your records.
Given that this is a brand new guidance, can Leading Age Michigan please seek clarity on the issues mentioned today?
Oh, we definitely are. There's no question about that. We haven't had a chance to do that yet, but I'm specifically concerned about some of the ideas about the medical practitioners entering the building, etc. We will seek more guidance. However, I do want to tell you that whenever it's an executive order or an epidemic order from Gordon, we get less responsiveness than if it's something clear about testing or reporting, et cetera, from the department. So it takes a while. But yes, we will be putting together and adding to our outstanding issues list in the next day or so.
All right. So if we have clinical students who come in 4 days in a row, 1 week only for a total of 20 hours, they are there more than 8 hours in one single week. Do we test before they start clinical? They would fall into a weekly testing, but they would be done before our next week's testing.
I think that it would be a good idea to have them tested before they start a clinical. You would have to test a new employee before you allow them in the building. I think it would be a good idea. However, the guidance isn't specific to it, but I would treat them the same way as I would other staff, just in this respect. And I would have them tested. Since you have time and you know that they're coming, I would test them before they show up. Even if they're only there for a week, I think that's a safe thing to do, especially considering they're younger people who tend to move about the community. And some of these communities continue to have high transmission rates, and they could very well be asymptomatic. So I think that it would be a good practice to have them tested before you allow them in the building. And then if they're only there for a week, they don't ever have to be tested again.
Okay. We have nurse aides licensed as cosmetologists. Since they are already screened, could they use our own or use our beauty shop to give haircuts?
Yes, I think that that was a point of conflict before this new guidance came out, but obviously you can provide hair care inside the facility if required, and I would think that they're cosmetology students, though. Is that correct? And nurse aides?
I believe she said that they were nurse aides that had cosmetology license. Let me go ahead and try to find that.
Yeah, I would think that that would be fine.
Okay. Would a tent with sides be permissible if there is ventilation?
Oh, I would think so. I think that, in fact, you know, in terms of making sure that you can protect from the elements, a tent with sides would be workable. I don't think you could have a entirely closed tent. You would have to have some ventilation moving through, but yes, I think that would work.
Would you think that a family member could visit in the facility for training and preparation for DC home if if the activity cannot be performed during outside visitation?
I think this has come up before, and I know that it's a challenge. I think that if indeed you can't figure out a way to really prepare the family and the resident for discharge home any other way, I think that probably you could make a case for the fact that this person would be negatively impacted otherwise. However, to be honest with you, I would think that in most cases you should be able to do it outside, weather permitting, or in some other way. You can still communicate electronically with people. You can still, have a Zoom meeting with people. So I think that for most cases you should be able to work around that, but I would make a case if I absolutely couldn't figure out another way to ensure a safe discharge, that the resident would be negatively impacted by not having that visit.
We have a clinical group who stated they were not going to come back to us, but rather to a different location because they are not going to require testing of students before they come.
Well, there is no requirement that says you have to test students. So I think that it's a best practice, but I don't think it's necessarily a requirement. And if you're not having them in the building for a significant, I guess it would depend on how long they're in the building. If they're in the building more than a week, I would think that you would have to do ongoing testing. If the other facility is not doing it, that would be a problem for them.
Okay. So by outside, that means open air and literally outside. What if we have an area outside the building that's enclosed, porch, igloo, contained pergola, etc.?
As long as it's open ventilation, I think that those places that would actually be preferred because they would provide some shelter from the elements. I think that porch, open air, anything where there's open ventilation would suffice, not in the building though.
What is meant by remote service delivery in reference to hairdressers?
I don't think that there is remote service delivery. I mean, I think that that's an example that they put in the guidance, but obviously that doesn't work for hairdressers.
Okay. You speak about weekly testing. Is this still only for nursing home? Is this still for nursing homes only, correct?
Yes. When we talk about weekly testing or any testing requirements at all right now, we are only talking about nursing homes.
Can restorative nursing do group exercises?
Yes, I think the same requirements apply to that as group therapy by therapists. You just need to make sure that you're doing social distancing, that you're in a well-ventilated room. People are wearing masks. They understand hand hygiene. They understand contact issues. I actually believe there's some people who've been doing some of these things already, but I do think that this guidance does clarify that that's allowed if outdoors doesn't work and in a well-ventilated room using all of the other safety precautions required.
Okay. People included in staff testing if in facility weekly more than 8 hours or 15 minutes. We have orders that say both. This is regarding service providers, not visitors.
Can you say that again, please, Blake?
People included in staff testing if in facility weekly more than 8 hours or 15 minutes. We have orders that say both. This is regarding service providers, not visitors.
I have seen most guidance that I've read says that if someone is returning to your facility and in the building weekly, period. They have to be tested on a weekly basis, as long as that person doesn't change week to week. If you have, a certain lab that's coming to draw blood, let's say on a weekly basis, but the person changes and you've got 20 different people coming, then that's different. But if you have a single person who's coming again and again on a weekly basis, my understanding is they have to be tested, whether they're in your building 15 minutes or 8 hours. I'm not sure about the 8-hour rule. I have not seen that clearly in guidance until this visitation rule came out. The CMS guidance says anyone who returns on a routine basis. And my understanding is that pretty much that means week to week.
Okay. Independent living has no ability to get such orders for decline. Could RSC documentation meet the need?
Can you repeat that again, please?
Yeah, no problem. Independent living has no ability to get such orders for decline. Could RSC documentation meet the need?
I would think so. I do know that the executive order, well, it's not an executive order, the Dr. Gordon's order from June 30 does include all of the care levels, residential congregate settings. And they do expect some documentation of decline. But since it's not a healthcare facility, I would think that they can't expect that kind of documentation from a clinical person, and I would just use your own documentation to support that. However, that is a piece that we'll ask guidance on. I don't know if we'll get an answer, but that would be my interpretation right now.
Okay. Are clergy considered non-medical service providers, and can they visit if need is documented?
I would certainly think so. I would certainly think that they would be considered an important part of anybody's care, especially for end of life or persons who are critical. I think that would go without saying, and that would fall under the exception rule. I think that they could be considered a non-medical service provider and subject to the same rules as that group as identified in the guidance. And I think that it would be easy to identify an actual or potential negative impact regarding that. So I would think that would be more than appropriate under the guidance.
Is a social work student considered clinical? Is a social work student considered a clinical student?
I think that they'd be considered a medical related student, yes.
Can volunteers be allowed to help if tested weekly and screened?
The guidance does say that volunteers can be used for visitation supervision, so I would think yes. But I would make sure that you adhere to all the other precautions as you would any other staff.
Okay. Can a screened porch be used for visits?
I would think so, as long as it's open. It just needs to be open. But if the porch requires walking through the building, I would hope that would have a separate entrance. I would think that you would need to look at that and again look at your structures.
Okay. The guidance says you have to treat students like employees, so seems they would need the testing before they start like new employees.
That would be my interpretation as well.
Okay. Visits are not permitted if there is a new COVID case originating in the facility, including those involving residents or staff, If we have a staff positive, we would not know if it originated in the facility or not.
I think that there's a couple issues here in my head. First is that there's an assumption that because that person is in your facility working, that counts as originating in the facility. You would have to consider that. The only time you don't consider a case of COVID in your facility as not originating there is if you've gotten an admission from a hospital or another nursing home facility who was known to be COVID on admission, or tested positive within 14 days after admission, according to CMS. You would need to consider all staff people as originating in your facility, whether or not they actually contracted it in the facility. That person is working in the facility on an ongoing basis, and therefore you have to consider that an outbreak. Now, can you repeat the rest of the questions because I forgot the other part?
Okay. So visits are not permitted if there's a new COVID case originating in the facility, including those involving residents or staff. If we have a staff positive, we would not know if it originated in the facility.
To be honest with you, I have to go back and look at the guidance because my read off the top of my head without it being in front of me is that it would not matter where you acquired the COVID case, but if you have someone potentially infectious, I don't think that you're supposed to be having visitation at all, except for those perhaps exceptions, and I'd have to go back and look at that as well. So let me review that and I will respond later. I think that when it comes to visitation, it comes to exposure, it doesn't matter where that case was acquired. But I will go back and check the guidance and see what it says because I don't remember off the top of my head. Forgive me for that.
Okay. Does this change the guidance on isolating dialysis patients?
No. Unfortunately, it isn't just dialysis patients. It's anybody who goes out of the facility for an appointment. You have to use full PPE and you have to isolate them for 14 days. And yes, I think that is overkill as well, but that is what CMS keeps telling us every time we ask.
All right, and it looks like last but not least, we're on the, oh, never mind, another one just popped up.
Okay.
Volunteers are referenced under outdoor visitation. Can you clarify what you said previously? They can be used indoors and outdoors. Families have considered applying to work or volunteer to have access to their loved ones.
I don't know that there's any consideration for volunteers in general here, and I don't believe that they are considered as essential for indoor activities at this point. So since this is the first thing that I can identify as allowing volunteers, I believe it is just for this outside visitation piece. So I think that I would be very concerned about allowing volunteers in and out of your facilities at this point. I don't think they're considered essential. But again, for all these questions, we will research them and get a little bit more direct answers as we can and as we re-review the guidance that just came out.
Okay. If we have a CCRC, can we separate out the cases for purpose of visitation guidance on the campus? So if we have a positive in the skilled area, we can't have visitors for 14 days, but do we have to cancel visitors for the assisted living area as well?
I would think that would depend on how you're structured. If you are all in the same building with potentially any movement between one area and another, I think that you're going to have to count that positive person as being in the entire community and not just the nursing facility or assisted living or wherever they are. But it depends on how you're structured. If you're in separate buildings, obviously, I think that you can say that the other facilities are COVID-free.
Okay. This EO seems definitely too little too late. Are others disappointed at the lack of progress, dental care outside?
I understand and agree. You know, the outside piece that came with these non-medical services didn't make sense, especially when the only example they gave was hair care. And I do think that outside visitation is long coming. This is my personal opinion. And a little bit late, considering what we really wanted was to have this happen in the summer when it made more sense. But we do appreciate the fact that at long last they did take some of our recommendations and ideas and put them into place. And we understand the challenges that everyone's facing every day. The state is very, very scared still about a second wave, and we understand that as well. The epidemiologists mostly have a lot of concerns about transmission going forward. So it's kind of a balance in their mind, I think, and but I agree with you. I think that safe visitation could have been done earlier, especially just outdoor visitation. The fact that we still have indoor visitation is a little disconcerting to me.
All right, it looks like that was the last question for now, so we can go ahead and move forward.
Don't move forward, okay?
Okay.
This has taken more than I really had planned on, and we are on noon. The rest of my presentation today is mostly about the chart report. I do want to talk about antigen testing, so we're going to skip a lot of slides here, and I'll talk about the chart report next week. So bear with me, and we will finish up in the next 10 minutes or so. So I'll move to the next slide.
Just let me know where to go.
Okay, so just flip through, flip. Okay, now. This is the CDC guidance for multifamily housing. I'm only going to spend a minute on it. Basically, one of the things that's a little bit different about this, and this was updated, I think last week, it identifies the type of housing that is to be covered under these recommendations, more specifically than we've ever seen before. So they actually identify Section 202 and 811 housing, project-based rental assistance, multifamily housing rental assistance programs, and any properties funded through the low-income housing tax credit. So these are the same basic recommendations that they have made for other residential settings, but they identify specifically that these apply to them. One of the things that we did note, and this was something that we went back and looked at the visitation guidance to consider, is unit turnovers. They do have a guidance for unit turnovers, but in Michigan, as far as we can tell from reading the visitation guidance, people who are not essential, who are not providing a specific service that's required, are still not allowed in the building. So we don't think that unit turnovers and tours are still going to work. But we will talk to the state about that again. Okay, so we're going to talk about, these last couple slides are really mostly about antigen testing. There was a CMS call on 9/8 at 6:30 p.m. with Seema Verma this week, and she noted that caseload was trending downward, but she still is concerned about, CMS is concerned about seeing practices and protocols in nursing homes that really have to be improved. She reminded everyone to check their community positivity rates on the data.cms.gov website, and remember the requirements that you do that every 2 weeks. It's only been about a week since they posted it. HHS is going to deliver, should have delivered all of the point of care equipment and test kits to nursing homes by September 30. There has been some problems with pricing. There have been some vendors that are inflating the prices for test kits, and CMS is going to be looking into that. They continue to focus on the fact during this call that antigen tests is a very acceptable way to do nursing home screening. CMS is also going to be purchasing 150 million Abbott point of care tests. And if you remember, those are the ones that use like a testing card and it's kind of done like a pregnancy test. But they're only going to be sent to nursing homes in red and yellow, which are high transmission areas. CMS did confirm during the call that contractors and other consultants must be tested as if they were staff. But when they're out of the building for a period of time, so they might, miss a month or so, they can be placed in the next testing cycle with the rest of your staff. You don't have to test them while they're gone. So then there were some leading edge calls with CMS this week. And this is the concept of enforcement discretion. They kept saying over and over in different calls that they're going to utilize enforcement discretion as long as there is identified a good faith effort that you can document that you're trying to get your testing done. So what they have clarified a little bit better is that there is a grace period for testing, and they mean reporting here, reporting of tests. For 3 weeks starting September 2nd. And that's only for reporting the results under CLIA. You still have to complete the test. There is no grace period for that. And if you can't get the test done at the frequency that you're required to based on your county transmission rate, you have to clearly document all of your attempts to try and make that happen. CMS does understand that some may not have the resources, but you have to document ongoing efforts. Another thing that they said this week was that there's new CMS visitation guidance coming soon, and we certainly hope that that's not going to make it more complicated in Michigan. One of the big issues is that Leading Age, in a conversation with CMS, identified that a report of 7 to 9 false positives that have been identified using the BD machine. So if you find a false positive, you are requested to contact BD. Leading Age is looking at the avenues to report these to the state and FDA. And BD is reporting problems to the FDA as well. So CMS is looking at this. They are aware that there's some false positives coming out of the BD testing. And so if you have a BD machine, Leading Age is setting up a live Q&A for members who have that equipment. They will put out information about that as it happens. So antigen testing, they updated the guidance again on 9/4. And all of the CDC documents again support the effective use of antigen tests for different testing situations. Again, noting that the proper interpretation of the test requires an understanding of the surrounding community risk. One of the things is that if you're doing point of care testing, you do have to have a CLIA certificate for waiver tests. The other concerns that the CDC has is that making sure that you get a good specimen, because if you don't have enough testing material, you could possibly test negative if there is a positive case. And you also have to make sure that you are careful enough to avoid any cross-contamination. There are also some biosafety measures, in other words, precautions about transmitting the disease during the process. And their best practice is to consider staff self-testing to avoid high PPE use. So if you have a supervising person more than 6 feet away, you really only have to wear perhaps a shield and a mask and gloves in order to assist with this test. So the CLIA certificate. Members, facilities are required that if you perform even one of what they call a waived test on any materials that are derived from humans for a diagnosis, you must have a CLIA certificate. And there are three kinds of tests. There are wave tests, moderate complexity, or high complexity tests. And obviously, moderate and high complexity tests are done in labs. Wave tests are those that are unlikely to be inaccurate based on user errors, such as urine dipsticks, which most people don't do anymore, but pregnancy tests, fetal occult blood, glucometers. And the FDA now identifies a point-of-care testing for COVID as a wave test. So to obtain a CLIA certificate for a wave test, the only thing that you have to do is make out the application and then attest that you will follow the manufacturer recommendations. And this is where CMS will temporarily exercise enforcement discretion for the duration of the emergency, because the manufacturer recommendations say that this is not a test to be used for screening, and that's what they are going to use enforcement discretion for. In other words, even though the FDA says, the manufacturers say this is only for screening, they're going to say, go ahead and use it for screening anyway. So if you want to know more about CLIA, I have three websites here, and one of them is how to obtain a certificate of waiver if you need to. This is our issues list. I can update it more and add to it for next week. I don't think we need to go through it now. The gold areas are the ones that we have gotten a response about. The rest we're still working on, but I do want to make sure that we have this outstanding issues list in front of you so that you can tell us what we're missing on an ongoing basis. There's some SNF QRP updates. We will put them in the newsletter. I will not go through them here since we're so short of time. So I ask you to review the newsletter. It should be coming out on Monday. And I think that should go to the end. Keep going. Keep going. There you go. So, any final questions?
All right, I do have a couple that popped up. Could you please clarify what is considered full PPE, N95, gowns, gloves, etc. for every resident who has an appointment outside of the building for 2 weeks following?
Yes, that is what that means, according to CMS, and we're still arguing about that to some degree. The CDC does not support that, but CMS continues to tell us that this is an exposed person who has to be a potentially exposed person who has to be treated as a PUI. And if you're going to treat them as a PUI, then you have to do all of that work. Sad but true.
All right. And can we change our testing based on positivity rates? I was told the state has not approved this.
You cannot, until the state approves it, you cannot downgrade your testing frequency based on testing rates, but you would have to upgrade your testing frequency based on transmission rates if needed. So there was one county last week, I think it was Luce of all places, that had a 13%, I believe, transmission rate in their area, and they're the only ones that I can remember would have met the criteria for twice weekly testing. So they would have to do twice weekly testing. But if you're in an area that, according to CMS, would only require monthly testing, you still have to do weekly testing because you're in the state of Michigan until they change it. Or your larger region, transmission rate goes down.
Okay. Does one CLIA waiver for anything cover all the CLIA waiver tests, or do you need a separate one for each test type? Example, glucose, urine dip, and COVID. Would I need 3 or just the 1?
You only need one CLIA certificate of waiver for all wave tests. You only need one. You do have to probably get them, though, for each entity. So if you have an assisted living and a nursing home on the same campus, depending on how, if you're not one entity for licensing purposes, you're going to have to probably get a CLIA waiver for both of those, but only one covers all of the wave tests, only one certificate.
Okay, this is more of a comment. Please add IL waiver communities to the outstanding items list.
They are on there.
Okay. If those who leave our building and must have 14-day observation be reported as a PUI on EMR CDC websites?
No.
Okay. So N95 masks have to be worn for caring for outside appointments and residents who go out for appointments.
That's my understanding from a recent CMS call, that anybody who is potentially exposed, and that's the reason for their 14-day quarantine, they have to be treated as if they are potentially infectious.
All right. It looks like that was the last question, so I will move over to this slide, just in case you do think of anything later in the day that pops in your head and you need to reach out to anybody. You can either email the Safe and Calm email, and I believe multiple people see that, or you can reach out to Deanna or Dalton directly, and I'm sure they will be able to answer any question for you. So now we would just like to thank Deanna and Dalton for all the information. And then we would also like to thank our members and participants. I believe we got up to around 95 members that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. I believe that takes care of everything that I needed to say. I hope everyone has a great weekend. Deanna or Dalton, do you have anything else you'd like to say?
Just be safe, everyone.
Have a good weekend.
All right. Thank you, and have a good rest of your day.